Hello, today's topic will be in another rheumatic heart disease, that is aortic regurgitation. In rheumatic fever, it licks the joints and bites the heart. There is no sequelae in the joints, though arthritis is one of the commonest presentation, but it leaves sequelae to the heart, and aortic regurgitation is one of the rheumatic heart disease. The aortic valve involvement is second common after the mitral valve involvement. In children, it is seen that rheumatic aortic stenosis is not seen, and pure rheumatic aortic valve disease is also almost unknown. It is occurring associated with the mitral valve disease. Come to the hemodynamic of aortic regurgitation. In aortic regurgitation, the aortic valve fails to close completely, so the blood flows back to the aorta, then to the left ventricle during diastole. Left ventricle is also being filled from left atrium. You can just see the left ventricle is receiving blood from left atrium as well as from the aorta. Left ventricle filled from two sources, aorta and left atrium. So there is greater left ventricular filling, increased left ventricular end diastolic pressure and volume, increased left ventricular end diastolic volume, that is the preload, will increase. This will increase the force of contraction according to the Frank-Starling's law, which is going to increase stroke volume in the aorta. So there is increased aortic systolic pressure, but aortic diastolic pressure is much lower than the normal, as blood from the aorta is rapidly moving due to the regurgitation to the left ventricle and also the forward flow. So there is a wide pulse pressure due to the difference. Increased systolic pressure and decreased diastolic pressure will lead to wide pulse pressure. Increased left ventricular end diastolic pressure leads to backflow of blood to the left atrium. That means back to the pulmonary veins or veins. It increases in left atrial pressure and also pulmonary pressure. So pulmonary congestion and pulmonary edema occurs, and then heart failure occurs. Backward flow of blood to left ventricle creates the diastolic murmur. Now come to aorta. Aorta is giving blood to two places. One is to the left ventricle, and the left ventricle increases in size, that is the backflow, and the forward flow. So since there is a backflow, forward flow is impaired. So due to that, this is compensated by peripheral vasodilatation and increased ejection from the left ventricle during the systole. So same thing I am just trying to show in a flow chart. If you see, there is a backflow of blood from aorta to the left ventricle during the diastole, and from aorta there is rapid fall of aortic pressure during diastole, because blood is flowing in forward and backward both ways. So when there is an increased left ventricular volume and pressure in the left ventricle, which has two effects. So due to the increased left atrial pressure, pulmonary venous pressure will increase, leading to pulmonary edema and heart failure. And this side, due to the increased left ventricular volume, there is increase in the stroke volume. Increased stroke volume will lead to ejection, which is ejected into the aorta. So there is a high systolic pressure. High systolic pressure this side, and in the aortic side there is a low diastolic pressure. So this will lead to wide pulse pressure. Now come to the clinical features. Number one clinical feature is palpitation due to large stroke volume. Pulse pressure is wide, which indicates severe leak. Our severe aortic regurgitation, diastolic BP can even go to 0. So creating a very wide pulse pressure. So the wider it is, it indicates the leak is high. Now evidences of wide pulse pressure is seen with some clinical features. So number one is prominent carotid pulsations known as Corrigan sign. Visible arterial pulsations over the extremities known as dancing peripheral arteries. Visible pulsations of the abdominal aorta. There are some other signs in aortic regurgitation which is noted. Number one is de Musset sign. So this is nodding of the head with each systole, which is due to sudden filling of carotid vessels in severe aortic regurgitation. Another is Hill sign, increased systolic pressure difference between the brachial and femoral arteries. Normally, if you see, the difference is 20 millimeter of mercury, femoral pressure being higher. So in Hill sign, this increases more. And de Rose's sign, here if you partially occlude an artery and then try to listen with the chest piece of your stethoscope, if you place the chest piece in the proximal part of that partially occluded artery, you get a systolic murmur. And if you put the chest piece in the distal part of that partially occluded artery, you get a diastolic murmur. So this is known as a de Rose's sign. Typical signs of aortic regurgitation. Other clinical features are arterial pulsations are present in the nail bed, uvula, lips, earlobe and eye grounds. Pistol shot sound is heard that is present over the brachial or femoral artery without applying any pressure you can hear this sound. An examination of the precordium in case of aortic regurgitation will show you the apex will be displaced downward and outward, and it will be heaving and forcible type. You can hear get a diastolic thrill in the upper left or right sternal border. First sound is soft, second hard sound, A2 is audible. Murmur, you get a high pitched decrescendo diastolic murmur along the left sternal border which radiates to the apex. Ejection systolic murmur is present at the second right intercostal space. And in investigations, you do X-ray chest that will show you left ventricular cardiomegaly and the dilated ascending aorta. If you do ECG, you'll find ventricular hypertrophy and left atrial enlargement. And when you do an echo, you get enlarged left ventricle and dilated aorta. Thank you. We'll meet you again in another class.